Good afternoon. This is Dr. John Bennett televising from Miami Beach. We have another episode of Jordan Neurosurgical Grand Rounds with Abraham Sabaya. We like to thank him for being patient with us. We had another webcast before. So I'll turn it over to Dr. Sabaya. It's all yours.
Thank you very much. We'll start. Okay. Right. Good day, good night, whatever time is, and I really enjoyed the previous webinar. I enjoyed the very innovative idea of the Ignite journal by IVE, and enjoyed listening to the other panelists. I'm Abraham Sabaya from Jordan, and we are transmitting live here from Amman, from the Farah Medical Campus. I'm going to discuss brain tumors in tuberous sclerosis complex. This is a view of the Dead Sea, and I was asking me how this lady is floating, and my answer was that there is a high concentration of salt in that Dead Sea. There is no marine life whatsoever, and the heavy water will just carry you up. You just can lay on the surface of the water reading your newspaper. This is the lowest point on Earth at about 460 meters below sea level. We're going to discuss, as I said, the brain tumors in tuberous sclerosis complex, and as usual, we'll discuss it thoroughly from the clinical, radiological, operative, and pathological points of correlation. Tuberous sclerosis. It was first described by a few people. Von Recklinghausen in 1862, Bourneville 1880, and Vogt in 1908. So this is von Recklinghausen. Actually, he did not describe a disease. He described a fetus who died out of whatever, and he discovered that he has brain regions. Then came Bourneville in 1880, and he actually had an epileptic patient who died, and post-mortem showed sort of potato-like masses in the brain of the patient. Then came Vogt in 1908, and he described the classical triad of epilepsy, mental retardation, and adenomyocytation. We will allude to this later on. So what is tuberous complex? Tuberous sclerosis complex is the terminology used all over the world to describe this autosomal dominant genetic disorder. So this is the genetic disease, and something like 2 to 5 million people around the world are affected by it. So the father, the mother, they can have affected boys or affected girls. What is the problem with this mutation of genes? There are two genes. One is located at a certain locus, and the other, both are important for maintaining cell growth and proliferation. And they are called tuberous sclerosis complex 1, tuberous sclerosis complex 2, two genes. And these two genes will allow the cell proliferation, and that is through mammalian pathway of rapamycin. Again, I will allude to this later on. So the genes responsible for the protein production is hamartine and tuberine. They are the ones that would suppress tumor formation. And once there is a genetic deformation of the hamartine and tuberine, and then tumors would grow. So it's a mutation. One of them is more common, which is as the 16 gene, and the other is at the 9th. So this is related to hamartine, and this is related to tuberine. This is the more common one. So this Genetic mutation will lead to inhibition of the mammalian target of rapamycin, and this will result in the growth of hamartomas in any organ or tissue, as we will see. What happens? There will be improper differentiation and proliferation and migration of neurological cells during fetal development. That's in the CNS. Look at this. This is normal organized brain cortex. This is tuberous sclerosis complex, totally disorganized, dysmorphic cortex. So you can see the normal and the tuberous sclerosis. Look at this normal brain cortex, and here is markedly disorganized lamination, neural elements, and the glial elements. And what happens is that if you take histology, you will see dysmorphic neurons. They don't look like any neuron anymore. And there are balloon cells, which are the characteristic cells of the tuberous sclerosis. So as I said, that the absence of genes lead to activation of the pathway, which leads to proliferation and formation of hamartoma. And this would be a multi-systemic disease. Let's see. Ophthalmological manifestation of the disease. This affects 50% of patients with tuberous sclerosis. This is very common. Once you have a tuberous sclerosis, you have to see the ophthalmologist for further details, for further examination. 50% of patients of tuberous sclerosis, with the tuberous sclerosis, they have ophthalmological manifestations. Like what? Let's see. Retinal hamartomas. You can see the hamartoma there, everywhere. Again, retinal hamartomas. Now this is a tuberous sclerosis with optic nerve hamartoma, just sitting there. This paper from Denmark, 2015, optical coherence, optic OCT of a maculopathy in patients with tuberous sclerosis. Again, they're describing this of the optic nerve. What about cardiac? Cardiac can be the cause of death in these patients, in addition to the CNS tumors, but cardiac rhabdomyoma is a killer disease, and it affects the heart of usually children, but can affect the adults too. This is cardiac rhabdomyoma. This is fetal rhabdomyoma. And this is giant rhabdomyoma, left ventricle. And here we have multiple rhabdomyomas of the 4 chambers of the heart. In the lungs, we have the lymphangioliomyosarcoma, the LAM. Lymphangioliomyosarcoma, LAM, affecting the lungs like this. Again, you can see it in all these X-rays and CTs. Renal, again, 50 to 80% of patients have renal disease, and it is also one of the killers in these tuberous sclerosis. And the kind of presentation is angiomyolipoma of the kidney, or a polycystic kidney disease, or renal cell carcinoma. So you can see that tuberous sclerosis is a multisystemic disease, and it's a killer disease. Bilateral angiomyolipoma is very bad, and it's almost incompatible with life. Renal cysts and renal carcinoma. Liver also can be affected by cysts or by angiomyolipoma. The most distinct of the affection of the tuberous sclerosis patient is the dermatological findings, and this is affecting 90% of patients. And as this disease is a disease of childhood, so there is a great burden on the pediatricians and general practitioners to really understand this disease and discover the cases early on. It affects the children more, it's very disfiguring, it is very distressful, it's very painful. Look at this, adenoma sebaceum. It is not adenoma sebaceum, it is angiofibroma. And it looks like red papules which contain blood vessels on the face. look at the various manifestations of these angiofibromas in kids and in adults, if they are lucky enough to reach that age. Can present not like papules, but like plaques. And if you look at that skin, this is very important. There is hypopigmentation, not like the papules, hypopigmentation, and they deserve this, the ash leaf, like the ash leaf spots. So you can see these hypopigmentation, which is as important as the papules or the plaques on the surface of the skin. The shagreen patch like this is very important. This is usually mistaken for psoriasis, but if you look carefully, it's not psoriasis. If you open the mouth and look at the teeth, you can see that the teeth, they have enamel changes, and you can see this gingival fibroma, very characteristic, and it is one of the main features of this disease. Periangual and subangual fibromas, look at the nails here and the feet here, these angiomas and fibromas in the feet. So we are speaking about, it's a voice. We are speaking about the dermatological affection, and we are speaking about the neurocutaneous syndrome. This is a very, very interesting paper to read. Cutaneous manifestations of a tuberous sclerosis complex and the pediatrician role. There is a very important role for the pediatrician and the general practitioner to find these cases, to diagnose them, to guide them what to do. Let's look at what happens to the nervous system, which is our goal here. There are so many manifestations of this disease, but let's start with the main ones. The tubers in the cortex or subcortex, then the subependymal tubers or nodules, and then the main tumors, which is the SIGA, subependymal giant cell astrocytoma. Let me start with the first manifestation, which is the tubers, cortical, subcortical, and the white matter, and it affects 90 to 80% of patients. So we should be able to see it if we look carefully. So this is tubers, as you can see, and they are usually calcified. Cortex or subcortex. Again, here on the MRI, you can see them. Here, the cortical tubers. 90 to 100% of patients, cortical tubers. And there is something in addition, which is the migration lines. You can see this, the lines like this, the migration lines going like this, or here, look at these lines. And here, in the frontoparietal area. The second common manifestation of tuberous sclerosis is the subependymal nodules. Again, 95 to 100% of patients. So you can see the subependymal nodules. You can see here some cystic degeneration within the subependymal nodules. You can see them here. They can be in any part of the ventricle, but we will see that they have a predilection. Look at this paper. Intraventricular regions in tuberous sclerosis with possible association with the caudate nucleus. It is definitely proven that these lesions, they take the shape of the caudate nucleus, head, body, the antrum, and the tail. Commonest part is the body and the head junction here. So why is that? Nobody knows. Still unclear why they develop at the distribution of the caudate nucleus. And they are common in this part, as I said. So one should know the anatomy of the caudate nucleus and look with these lesions whether they follow this distribution of the caudate nucleus, the head, the body, and the antral part and the tail part of the caudate nucleus. So you can see here, lesions are going along the caudate nucleus. So there's some association that we don't understand. These subependymal nodules, they can calcify, as you can see. And once you see that calcification, you would ask yourself, whether a pediatrician or general practitioner or neurosurgeon, what kind of calcification is this? and this normal, physiological, or pathological. The third part, which is our topic for today, is the SIGA, the subependymal giant cell astrocytoma. And again, this is 5 to 20% of patients. But because it's very important and because it can be a killer, we have to address it. It's benign lesion, it's an astrocytoma, and it's grade 1. On CT, as I said, they could be calcified, they could be not. They could be small, they could be large. Again, MRI would show you that this lesion is concentrating around the foramen of Monro and associated with subependymal nodules. So you may find the subependymal giant astrocytoma and the subependymal nodules and the cortical and subcortical tumors. T1 with contrast, you can see the SIGA here, and there, and could be bilateral. And this is most dangerous. Bilateral SIGA at the foramen of Monro can present with acute hydrocephalus, and it can kill patients. Can they progress? Definitely. The natural history, they progress. As you can see here, this 21 months, 35 months, 52, 65, 74, so it's growing. This is from New York. As I said, it could be small, it could be giant like this. So once you see this, you say, oh, it is not a tuberous sclerosis, it's not a SIGA, it can be very giant. It can calcify, as we said, like the subependymal nodules, and you can get hemorrhage into these tumors, which can also present with acute manifestations. Paper from Japan. PET scan would show you decreased activity. And FDG PET, again, will show you focal reduction. So this is a focal reduction here. Hypometabolism, here, here, there. Sorry. This beautiful paper from Mayo Clinic, the ability of high field strength 7 Tesla to reveal previously uncharacterized brain lesions in patients with tuberous sclerosis. 7 Tesla from Mayo Clinic, published in Neurosurgery. And they have put the 1.5 Tesla images, and they show you the 7 Tesla showing more lesions that you did not see on 1.5. 1.5 Tesla and the 7 Tesla. You have seen lesions that you did not see on 1.5. Same here, see this, you see this, but here you see more details and more information. And the same here. So 7 Tesla, although it is still in the research, I think it is starting to sell as for clinical use in the United States. So, how do you diagnose tuberous sclerosis? You need 2 major features or 1 major and 2 minors. 2 major, 1 major, or 2 minors. Let's see. The major ones, as we said, the facial adenomyocytoma or angiofibroma, the subangular fibroma, the shagreen patch, which I described, the forehead fibrous plaque, the cortical tubers, the subependymal nodules, the bilateral renal angiolipomas. These are major criteria. Look, all these in the various parts of the body. And this bilateral renal angiolipoma is very, very characteristic. The minor features are polycystic kidney, single renal angiolipoma, pulmonary lymphangiolipomatosis, or a cardiac rhabdomyoma. So you need 2 majors or 1 major or 1 major and 1 minor. What about the pathology? This is the pathology done by my colleague, Dr. Samo Farsakh. We've been doing this together for a very long time, and we have published many papers. And this is one of these specimens, a gross appearance. And again, as I said, he will show you dysmorphic neurons, the balloon cells, and so on. These are balloon cells with some fatty adipose tissue. The NC is positive. the GEMSA for mast cells, showing these mast cells in here. The GFAP is positive. Synaptocene is positive. S100 is positive. EMA obviously is negative. Ki usually is low because these are benign lesions. So what is the clinical manifestations of these cases? As I said before, epilepsy, 80% of cases. Autism, 25 to 40%. So whenever you have an autism child, try to look for a very strong association with the tuberous sclerosis and do the most sophisticated MRI to join the link between the autism and the tuberous sclerosis. Of course, it's always associated with developmental delay, bad school progress, and so on. But the commonest is epilepsy. If you see one case of these tuberous sclerosis lesions, what is their differential diagnosis? I'll take you to this very interesting slide. Frequency of intraventricular tumors, 20% ependymoma, 20% astrocytoma, angiomas, colloid cysts, colloid plexus papilloma, central neurocytoma, subependymoma, and miscellaneous, which is very small, is the subependymal giant cell astrocytoma. Again, you have to be aware, are you dealing with a child or an adult? And where is the tumor located? Anterior horn or body or trigone or foramen mauro or third ventricle? So each has a predominance, like here in foramen of Monroe. In a child, the SIGA is commoner than in children than in adults. And once you see calcification, as I said, this disease can present with subependymal nodules or SIGA, which are calcified, so I have to know the differential diagnosis of calcification, which could be normal physiological in the basal ganglia like this, and the choroid plexus, and the pineal gland, or it could be due to hyperparathyroidism, or it could be to various diseases, calcification in influenza, in malaria, in HIV, in toxoplasmosis. The commonest, as I said, are ependymomas on the region of the foramen of Monroe. 16-year-old male patient, a patient of mine, another patient of mine with this ependymoma. Again, here, look, shunt has been put, and I will allude to this. I find it very, very strange that people put a shunt for all these intraventricular lesions for no good reason. If they have this tumor in their children, boys or girls, they would not accept to put a shunt. Putting a shunt is a sign of weakness of the surgeon because he does not know what's the next step. If he has put an external drain, then he has a next step to do, which is excision of the tumor. But once he has put a shunt, meaning that he closed the file, he is not going to do anything further. So for me, putting a shunt in intraventricular tumor is a sign of weakness and incompetence. Patient of mine, 34-year-old with astrocytoma grade 1, again at the foramen of Monroe. Various pilocytic astrocytomas in my series, astrocytoma grade 2. All these cases are cases of mine. Astrocytoma grade 3, chordoid glioma. It is not mine, from an book. Oligodendroglioma, intraventricular meningioma, colloid cyst, which I presented last week, and this is one of the largest colloid cysts in literature, patient of mine. Choroid plexus tumors, be it a choroid plexus papilloma or malignancy or the aggressive type, which is a grade 2. A neurocytoma, central neurocytoma, a patient from Sudan. Again, various neurocytomas, I had the pleasure of dealing with them. This patient of mine is a nurse, a Jordanian nurse, 30-year-old male patient with this tumor, central neurocytoma, subependymoma, and this man from Iraq. This is Jordanian lady with subependymoma. So we have the astrocytoma, we have the ependymoma, we have the subependymoma, and we have the subependymal giant cell astrocytoma. So all these can present with tumors around the foramen of Monro. Craniopharyngioma, 5% of them, they are isolated completely inside the third ventricle. Germinomas, and look at this one girl I had from Iraq, 11-year-old, with this huge tumor at the foramen of Monro, and that turned out to be a germinoma. We did excise it and gave it radiotherapy, and she's now what, about 18-year-old, about 9-year follow-up without any recurrence. Yolk sac tumor, the same like germinoma. PNET, primary neuroectodermal tumors at the region of the foramen of Monro. A lymphoma, and people would think that lymphoma would not present intraventricular. They can. And this is one case of mine, 10-year-old girl from Kurdistan, with this, Kurdistan, Iraq, with this huge tumor intraventricular that turned out to be lymphoma. This is the histology. Intraventricular metastases, again, people think that metastases would not be inside the ventricle. They can be. I have seen them, I have dealt with them. Cavernoma inside the foramen of Monro, teratoma, corpus callosum lipoma, as you can see here. And here, the epidermoid and dermoid in the region of the foramen. Tuberculoma, especially in the Middle East, in Yemen and in other countries, we have intracranial tuberculomas. Sarcoidosis follow. Cysticercosis, look at this. You can easily miss this for any other of the differential diagnoses that I mentioned. Histiocytosis X loves the area in the cellular supracellular area. Aneurysm, if you are not careful, basilar tip aneurysm can really be there at the foramen of Monro. So you can see that the differential diagnosis is wide, and I always recommend the young neurosurgeons and residents to have a long list of differential diagnosis and then try to see 3 or 4 limited options of the diagnosis. What's the treatment of this SIGA? Either you observe, or you do surgery, or you give pharmacotherapy, which is the mTOR inhibitor, the mammalian track of the rapamycin, radiation therapy, or a gamma knife. Observation, if you have a case which is asymptomatic and there is no fear of actually observing and doing serial imaging. Surgery, your aim as in another tumor to eradicate, but sometimes you have to accept defeat and leave a tumor there. And luckily, literature tells us once you leave a small piece, it rarely grows again. Somehow it is suppressed and does not grow again. Of course, there are cases of recurrence, but I will show you in many of my cases there has been no recurrence in leaving a small part, which is, as you can have seen it from the previous lecture, is difficult to remove from the area of the foramen of Monro, from the fornix, and from the other nuclei there. So complete resection is difficult in some cases because of attachment to important structures. Look in paper, this is a paper by Yazarjil and Salim Abdurraouf. At that time, Yazarjil was still at Little Rock, and Salim has moved to St. Louis, Missouri, and they are showing this tumor intraventricular done by Walter Dandy. Paper from Poland with the surgical treatment of the subependymal giant cell astrocytoma. Conclusion. Their study indicated that subependymal giant cell astrocytoma is associated with significant risk in which individual? Bilateral and tumors bigger than 2 centimeters and in children. So these are the criteria of difficulty and where you have to leave a small piece of the tumor. And they have put this sketch here. As I said, the tuberous sclerosis complex 1, tuberous sclerosis complex 2, and you can see the complication rate is higher in this complex number 2 and in younger age of patients and in the large size of the tumor. This paper from France, surgery for subependymal giant astrocytoma, they describe 18 patients over a period of 10 years They have done microsurgery in 17, endoscopy in 1, and they have recurrence in 3. What are the approaches? Many approaches for the ventricular system depending on where the tumor is, but most of the time SIGA is around the foramen of Monro, and the approaches are either transcortical or transcallosal. Transcortical, as you can see, the idea is to go through the sulcus between the superior and middle frontal gyrus, or through the middle frontal gyrus with inclination to go into the ventricular cavity like this. And this is some of the MRIs of my patients showing the point of entry. Again, here you can see the point of entry here, here, there, and there. And this is the transcortical, you can see going into the corpus, going into the ventricular system. So cortical incision and then deep into the ependyma. And here, Arun Cohen-Gado described this paper showing that he's using this introducer to do the job. Transcallosal, same, go through the midline, and we have seen this in the previous lecture. Pablo showed it, just the same. You have to find, actually Pablo described a very good technique which I use. I leave this vein like this and I cut the dura here, and I cut the dura here and reflect it. So you keep the vein, if it is going into the dura, intact. If it is not going into the dura, then just arachnoid dissection will give you that space. And once you go in, you see the pericallosal artery, you split the corpus callosum about 1.5 centimeters, and then you get into the ventricular system. So this is transcallosal. You cross the midline. As you can see here, this is sagittal sinus. Again, you would find the vein, which I described what to do with them. In this case, you just cut the dura this way, and leave the vein intact. Into the callosum, you can see the pericallosum and callosum marginal. Here they are. You go in between, find the white color of the corpus callosum, 1 to 1.5 incision in the corpus callosum to avoid any dissociation between the two hemispheres, and then you are into the ventricular cavity. Again, this is transcallosal. You go right or you go left, but most of the time, whenever I go transcallosal, I find myself on the left side. And once you go through the corpus callosum, you can go paraforniceal or transchoroidal or interforniceal according to where you want to go. So here we are, foramen of Monro, thalamus striate, septal vein, and you go in here. Again, thalamus striate, septal vein, and you go in here. This is the tinea fornicis. So this is thalamus striate, septal vein, superior choroidal vein, choroid plexus, and then you cut here through the tinea fornicis to go into the third ventricle. I want to elaborate on this shunt. I keep saying that this is a disease in the underdeveloped countries where a shunt is put in anybody who is having any ventricular obstruction for no good reason. As I said, putting a shunt for intraventricular tumors, maybe this is the treatment, maybe eventually this is the treatment, but it should not be put up front. And the argument that people use is that this was an emergency at 3 o'clock in the morning, so we did not want to do major surgery. Okay, a shunt will take time. External ventricular drain will take no time. So put an external drain. But as I said, once you have put a shunt, you have closed the file. You have no further step to do. You are not going to do any further craniotomy for excision. So I know you are incompetent. Look at this here. The thing will grow, and the shunt is there, making surgery difficult. Shunt, lesion, growing further. Again, large one with the shunt. Again, I mean, there is no explanation for me, except for incompetency of the surgeon who is doing it. And the worst scenarios of all is the bilateral shunt. And people would speak about Y-shaped connection, and they are describing as if they are describing a battle. Y-shaped connection, and I put bilateral shunt. This is crazy, and to me, this is a crime against humanity. Endoscopy, as I said, in the hands of the endoscopist lies the future of neurosurgery, and there have been many descriptions of the endoscopy used for intraventricular regions. The limitation in endoscopy is that these lesions are very vascular, and they would bleed heavily. So maybe endoscopy for these cases is not the first choice, but it's in the good hands. It is one of the choices to go for. Radiotherapy outcome is disappointing. They are using the laser interstitial thermal therapy now for treatment, and this is some of the papers published from USA. The MRI guided laser interstitial thermal therapy, as you can see, the treatment here, and 6 months later, it is surrounded by this killer area or killed area. Another paper from USA about the laser interstitial thermal therapy used for this, for treatment and after treatment. Gamma knife, there is uncertainty about its efficacy and lack of safety over the 20 years period when the Lansford group treated only 6 patients with these cases. So these are limited for recurrent tumors. As I said, the pharmacotherapy is to use the pathway inhibitor, everolimus or tismirolimus. This is FDA approved drug, and it can affect these cases. This is before treatment, this is after treatment. Before treatment, 3 months later, 36 months later. So there is a pharmacotherapy for this. Another paper from USA about everolimus for tumor recurrence, here before and here after. Before and after the pharmacotherapy. So this is the one that we described as the rapamycin pathway, mammalian target of rapamycin. The limitation of the everolimus is that once you stop treatment, the tumor may regrow, and you need to use it for a long period of time. It has many side effects. Another paper from mainly USA about the efficacy of this before and after. Now, last portion of my presentation to tell you about my series. I had 11 cases. I was so lucky to have this number in the years 90 to 2020, about 30 years period, to have 11 cases of CGAM is very important. I've lost 5 cases for follow-up, so I'm going to present to you the 6 cases which I have followed and I have documentation of. For all patients, we do full ophthalmological examination, including optic OCT, visual fields, fundoscopy, etc. We need to know it before and after treatment. We send all patients for genetic testing, and we do neuropsychology assessment. We do skull X-ray, and you'll be surprised that skull X-ray is still very useful, and you can see the silver bead in appearance because of the hydrocephalus. We do the MRI, various MRI sequences, MRA, MRV, and for me, MRI means brain MRI, brain MRA, brain MRV, they are one and the same unit. It's very important to know the location of vessels and the bridging veins. And we also go for systemic investigations if we are in doubt, chest X-ray, and to look into the spine if we are thinking of any dissemination. So I performed microsurgery in 6 cases, and they were all transcortical, and I have long follow-up on them. I always end the surgery by putting external drain to safeguard against any blood clot that would close the aqueduct or whatever, to make sure that there's no need for a shunt. Complications, of course, like any other neurosurgeon, I have the subdural hygroma, bilateral subgaleal collection, meningitis, DI, hemiparesis, and so on. Illustrative cases. I started this case, 18-year-old female who's a Jordanian residing in United Arab Emirates. She had epilepsy at the age of 2. At that time, in United Arab Emirates, they have done this MRI, which did not show any abnormality. At the age of 7, she was still having seizures. She had poor school performance. And the MRI then, at the age of 7 years, showed this lesion. Nothing was done. At the age of 17, she had larger lesions with hydrocephalus. Nothing has been done. And you can see that she developed this huge dilatation of the ventricle, especially on the left side. But if you look at the MRI, you can see that this lesion is really going into foramen of Monro, affecting the columns of the fornix and in the deep areas of the anterior horn of the lateral ventricle. And again, you can see it here and in here. So this is a story to tell, really, and I just want you to go with me into the understanding of how these tumors behave. This lady came from United Arab Emirates on an airplane. She arrived to the airport. We sent an ambulance to bring her. She just arrived, just put her in her bed, and she arrested with fixed dilated pupil on the right side. CT scan on the way to theater showed this. We have put external ventricular drain. External ventricular drain takes 10 minutes max. You don't put a shunt in emergencies. So to tell me that I had to put a shunt because it was an emergency at 3 o'clock in the morning, my answer to this, put external drain. But you do not want to put external drain because you have another step to take which you don't want to take. So this is the CT scan and this is the external drain we have put, saving her life. Having recovered, we assessed her from the psychological point of view. Our associate, our psychiatrist, Dr. Walid Sarhan, who is a very senior psychiatrist in Jordan and in the Arab world, performed the Karnofsky performance scale, and he's done other things, and he decided that her Karnofsky was 50. She requires considerable assistance. Sorry. Her IQ is 60 with mild mental retardation. Interpersonal sensitivity and anxiety as mild high score. We did surgery for her, and this is the immediate postoperative MRI, and this is the postoperative course of the patient. My observation of this lady was fair in color. She had fair hair, fair skin, and she had colored eyes, which may be something. This is not common in Jordanians to have this kind of color. So here she is, did very well. And we followed her, and at 4 years of follow-up, still this was seen, and follow-up MRI did not show any changes in that. Confirming the opinion which I'm making that if you remove the major part of the tumor, the residual part, most of the times, will not grow. Did I give radiotherapy? No, I did not. I would not. Believe me or not, believe me or you don't believe me, that this is the sister of the first girl. The first girl was 18-year-old. This is her elder sister, 20-year-old female, Jordanian, residing with her husband in Kingdom of Saudi Arabia. And this is her MRI. You can see almost same like her sister. And again, another story. She came by airplane. We sent an ambulance. Ambulance just arrived to the ICU, and she arrested. And we had to put an external drain. And this is after surgery when we removed her tumor. And this is 2 years follow-up. Residual lesion, which is not affecting her by any means. This is her again, doing very well. Now, this is the story I want to tell you. This is a Jordanian girl residing in Jerusalem, in the West Bank of Jordan with the Palestinian Authority. And she's married, she's pregnant, and She wanted to deliver, so they have put an epidural, and with the epidural, she arrested. Why? Because she had severe hydrocephalus with this. How did she survive? I have no idea. She survived by some means, and she was brought to us with this huge tumor. Again, we did the surgery, and this is immediate post-operative. And this is the follow-up of the very small residual, which I did not remove because it was attached to the fornices, to the columns of the fornices. This is the girl herself, and this is the follow-up. She's doing very well. She is now residing in Jericho, the West Bank of Jordan. And this is the story to tell. Jordanian family with the 3 sons affected. 3 sons of the same family, Christian family. By the way, 18% of Jordanian people are Christians. Christians, Muslims, and Jews have been living in this area for so many centuries without any problem. Jordan is a very religious, tolerant country. So this Christian Jordanian family, I got this picture for you. 3 sons. This is the elder son, the middle, and the youngest. Again, the first child presented to me as an emergency. This is the elder son. When I saw him, I asked to see the rest of the family. This is the female, this is the male. So the mother is a carrier. And this is the elder brother, middle brother, and young brother. So the elder brother presented to me as a very top emergency, which we did for him. And this is the immediate post-operative. We don't go to all the subependymal nodules. We go for the culprit, for the one which was causing the hydrocephalus. And I followed the elder brother. I received them 88 as an emergency. I followed them up till 2008. And unfortunately, he committed suicide. He wanted to get married, and he could not find a girl to get married because of his disease, so he committed suicide. I brought the middle brother and did CT scan on him, and he had also hydrocephalus, and I operated upon him. Same year, post-operative, still subependymal nodules, which we did not touch. Again, we followed him up till 2018. That is 30 years of follow-up without any radiotherapy, whether for the elder brother or the middle brother. For 20 and 30 years, we did not give any radiotherapy. The youngest brother follow-up did not show, except for increased number of subependymal nodules without causing any problems for them. And this is the follow-up for 30 years. We followed the mother. The number of subependymal nodules increased. She's a carrier, remember. The father remained free. And this is the picture for the family 29 years later. We published this in the Pan-Arab Journal of Neurosurgery as a very unique case of 3 members of the same Jordanian family. Before we go into surgery, to remind you of some of the anatomical features, to go into that area, you have to have a full knowledge of the anatomy of the ventricular system, especially the third ventricle and the lateral ventricle, the roof and the anterior floor, and all the walls of the lateral and third ventricle. This is the corpus callosum, and this is the fornix, and this is the choroid plexus in the roof of the third ventricle. This is foramen of Monroe, and this is again the body of the fornix here. And you can see the anterior septal vein coming this way. The Thermostat comes this way. It will be joined by the superior choroidal vessel, and they will form the internal cerebral vein. So removal of part of the corpus callosum on this cadaveric specimen, you can see anterior septal joining with the Thermostat to form the internal cerebral vein. A frontal view of the ventricular system, you have to have this 3D imagination of the anatomy. If you are looking from the superior aspect, and then looking at the both ventricles, then coming to the area of foramen of Monro, you can see the septal vein, the thermostat vein. Here, hidden underneath the body of the corpus callosum with the septum lucidum on top is the internal cerebral vein. So here you are, septal thermostat forming internal cerebral vein, superior choroidal vein, same picture here. This is the fornix coming from right side, left side, joining together to form the body of the fornix. So crus from the left, crus from the right, body of the fornix and the columns of the fornix. Same picture here, the body of the fornix hiding to us the roof of the third ventricle, septal vein, thermostat vein. Here we have removed part of the body of the fornix on the right side. As you can see, septal vein, thermostat here. This is the branches of the medial posterior choroidal artery. Again, showing the same features as we described. So you should not go into that area unless you know the exact anatomy. Be studied in textbooks and then go to the cadaveric lab, and then you might venture to go into that area. Intraventricular regions, especially in the third ventricle, especially in the foramen of Monro, are very challenging. Again, you have to understand the vascular relationship. The septal vein, the thermostat vein comes from the anterior, middle, and posterior caudate veins and forming the internal cerebral vein. And then here the vein of Rosenthal to form the vein of Galen. I always refer to this view from Yazarjil's book about this 3D imagination of how these veins are connected, anterior septal thermostat forming internal cerebral vein here, internal cerebral vein here, vein of Rosenthal joining us. So you need to know all this, and you need to know the vascular relationship with the foramen of Monro. Here you can see the internal cerebral veins, the thermostat vein, the septal vein, and so on. So important knowledge of the anatomy that you need, and also you have to be familiar with the relationship of the anterior septal vein and thermostat vein. Here is the normal side, here is the abnormal, and the anterior septal and thermostat. Look here how they join, look here, and look here. So they have different angles of anastomosis together. So always I'm referred to reading from textbooks, whatever textbook you like. Roten or Yazarjil or Sweet, whatever you like, but read from textbooks and do not read from handbooks. Please, for goodness sake, don't read from handbooks. Leave this handbook, which is by its name, it's called handbook. It is something you read the night of the exam, but don't use it as a textbook. I sometimes use the navigation if I need to. As I said, I end the surgery by putting external ventricular drain for a couple of days. I will show you now some of the videos, and then we'll be finished. I think we are still on time. I will show you some simple cases. As I said, most of the time, these tumors are very vascular. In this case, I want to show you a less vascular tumor. Here I'm opening the septum lucidum, and here I'm holding the tumor, which is not very vascular, which is unusual from the area of the foramen of Monro. So for me, this was the simplest case of SIGA, subependymal giant cell astrocytoma in tuberous sclerosis patient. So here you are. This is the simplest case. Now we'll go for another one. Here's to show you how vascular these tumors are. This is transcortical approach, and you can see the tumor is very, very vascular, extremely vascular. When you touch it, it just bleed and bleed and bleed. It's full of vessels, So you don't know whether you are dealing with Thermostat vein or septal vein, or is it just a vein of the tumor, but they are really very vascular. And here we're trying to take the tumor off the foramen of Monro. Last piece of the tumor. And this is the area of the foramen of Monro here, and the choroid plexus. I always open the septum lucidum to make sure that hydrocephalus would not happen postoperatively, and I ensure this by putting the external ventricular drain. This is just to show you that we are on the right side. Here we have opened the septum. You can see the left side, and here we are opening the foramen of Monro here without encroaching on the columns of the fornix. But look at here, you don't find a plane of cleavage here. Here I'm just looking the other side. This is the anterior horn of the lateral ventricle on the other side. Here the tumor is really stuck to the area of the foramen of Monro, and I had to be careful in removing it. It was not suckable, and there was no plane of cleavage. I used the Cusa aspirator, and you can see that it is very vascular. So we'll continue using and this is the last piece here, which is attached here to the fornix. So I'm using a very low power of the ultrasonic aspirator, just like a sucker, as it were. So this is the problem with these tumors, that they are stuck, no plane of cleavage, in an area full of important structures, be it the caudate, being the thalamus, be it the thalamus striate, be it the columns of the fornix, and so on. Wash, wash, wash to prevent any blood clots accumulating within the ventricular system, and then open the septum lucidum and put an external drain. The last video, and we'll be finished. Again, here showing you how vascular these tumors are. This is the tumor as we have done transcortical. So it may look like sort of well encapsulated, but then you'll find that as you go deeper, it has the attachment to the structures around the foramen of Monro, mainly the caudate nucleus and the columns of the fornix. Very vascular tumor. Continue with the removal of the tumor. Look, here is the head of caudate. And if you go in here, the thing that the caudate looks like a tumor inside. So you have to be careful and stop. And this is the septum. This is the thalamus striate. And this is the blood vessel coming here to the tumor. Separating the tumor from the thalamus striate vein. Still a tumor, the foramen of Monro here. Trying to open here you can see the internal cerebral vein in a minute. There it is. So thalamus striate coming this way, septal coming this way, forming the internal cerebral vein. I'm cauterizing the choroid plexus to allow me to take as much of the tumor as I can. And here is the choroid plexus going into the foramen. ends by wash, 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 and the opening the septum and putting external drain. I always close the dura in a baggy fashion. I don't like primary suturing because I believe that to prevent any increase in the ventricular pressure, you have to have a baggy dural closure. With this, I finish, and I thank you for listening. I'm happy to take your comments and questions.
Okay, very good. Thank you, Dr. Sabea. Let me just get off the screen share here. Okay, very good. Okay, comments, or let me get my screen here. Any comments or questions from any of the panelists?
Yeah, John, hi.
Hi, welcome.
Yeah, this is Dr. Altaf from Karachi.
Hello.
And salam, Professor Ibrahim, an excellent presentation. And you are a great speaker and a great neurosurgeon, I must appreciate.
Thank
And we are supposed to learn a lot from you and your experience. And I have the honor of working with Professor Dr. Rashid Juma, who happens to be your contemporary at St. George's Hospital, London.
That's true.
Yeah. So I was just wondering that the two ladies had a flight and then they succumbed. Is there anything with the pressure of air which made them to succumb when they landed? Or that was a kind of intriguing thought for me.
The two sisters, you mean?
Yes. The
Yes.
one came when she was being shifted to hospital, she collapsed. And another one, same story. So do you think that the raised ICP was compounded by the flight?
I have no doubt about that. I have no doubt about that. And we must actually understand that we know very little about the effect of air travel on the brain tumors. We just sign certificates that this patient can fly, but really we don't go deep into writing these reports. We have to be careful. Putting a patient in another plane of the brain tumor and hydrocephalus is asking for trouble, is asking for the patient to die en route. So people have to be careful. No, people did not realize this actually until she arrived here, and just on arriving here with the change of the cabin pressure. I mean, the cabin pressure now in the airplanes that we have now is stable, but you go up and down, so the barometric pressure changes, and there are changes on the intracranial pressure, and it is the cause of deterioration of these two sisters.
Right. So I completely agree with your analysis. So second question is, have you ever tried mTOR inhibitor in your patients?
Used what?
mTOR, what is it?
mTOR inhibitor, the tacrolimus.
No, I didn't. No, I did not. As I said, the teaching about these papers that it is a hefty drug, it has lots of side effects, although it is FDA approved, but you have to be very careful. And once you stop it with all the side effects that it can cause, the tumor can grow again. So I think we still need more time to evaluate the efficacy of this drug. I believe that if you have a very difficult case that you could not operate, or you operate and it recurred, that you can use the pharmacotherapy for these patients.
Right. And you also advise that these patients should also be followed for the lesions in other organs, including kidney and retina?
Absolutely. And for the brain itself, you have to keep long follow-up in them because they can develop other lesions, or the pre-existing subependymal nodules can grow. So they have to be under monitor all their lives.
And how often do you see the spinal lesions in these patients? Have you seen the spinal lesions?
No, I haven't. It is reported that there are some bony changes in the spine, and sometimes we have some migrations of cells, but I have not seen any case of spinal lesions in these patients of tuberous sclerosis.
Now, my last question and kind of comment: have you ever noticed, or have you any idea about conversion of these tumors into malignancy, or
Uh,
association of this disease with malignancy?
Yeah, it has been reported, but I have not seen personally. It has been reported that they can turn into aggressive or malignant cases simply by chronicity. Chronic, or the time of chronicity is one factor of tumors going high grade. Leave a low grade glioma, most likely it will go into grade 2 or grade 3. And I believe the same would happen with these SIGA lesions. Uh, so chronicity is an important point.
Okay, but thank you
But
very
we
much.
tend,
Go ahead.
last, sorry,
Go
sorry,
ahead. Go ahead.
but we tend not to operate until they become symptomatic.
Yes,
In SIGA.
there has been a paper or two papers advocating that once you see a lesion which you think is SIGA, although it is asymptomatic, you go and remove it. But lots of people reading the comments of the authors, comments to the authors about this, that this is not really on, this is a rather crazy approach, that you go and operate on something which is asymptomatic. You have to keep them under close monitoring, and it is the duty of the pediatrician and the general practitioner to see these cases preschool and at school. But people are missing on this part, especially in the underdeveloped countries. People are missing on these lesions.
Right, and removing the tumor will not cure the epilepsy.
It has nothing to do with the epilepsy, but removing it is life-saving, as I've shown with the hydrocephalus, but it has nothing to do with the epilepsy.
Thank you very much, sir.
Okay, thank you, Dr. Ali, for your participation. Samar Hose, how are you doing? Do you have a comment or question?
Hi, John, and thank you, Dr. Ibrahim, for the nice presentation. I'm Samar Hose from Iraq. Actually, just I have an idea in mind that in the colloid cyst, which close like a close disease to the SIGA, the subacute giant ependymomas, once a few reports about sudden death in the colloid cyst reported, just the trend of colloid cyst shift that even small, even symptomatic, should be treated surgically as soon as possible because of risk of death. That might maybe for the future, if any reports about sudden death from SIGA, that maybe change the strategy, even though we know that SIGA in most of the instances larger in size at the presentation than colloid. What's your opinion, sir?
Yeah. Last week I presented the colloid cysts, and I looked into literature and found that all through the literature presentation, only 104 cases of sudden death occurred due to colloid cyst. So to think that colloid cyst is going to cause sudden death is not realistic, right? It is not realistic at all. 10% of intraventricular tumors are colloid cysts. So to operate on these just because they are there is not a good policy. But we have to keep patients under observation. We have to tell them what to do. We have to tell them what are the symptoms and signs that when they develop, they have to come to us. I mean, this is my policy. I would not operate on something which is asymptomatic and something that for the time being is not causing any problem for the patient.
Okay, thank you, Samar. Abdullah, you had a question or comment?
Good evening. Good evening, Dr. Bennett. Good evening, Dr. Ibrahim. How are you? Thank you very much for your elaborated lecture. Actually, this disease is a dilemma for plenty of doctors. And the problem that, as you say, nobody is following and seeing the extension of the symptoms and manifestations of such disease. Anyway, well, I don't want to advocate. I'm like you. I don't like just to start with half treatment or even with a small procedure for something which is serious, and go for small procedures just to take money or, I mean, start something and say, okay, I treated your symptoms and you go somewhere else, or you don't go somewhere else to be treated. But going back to your 2 cases which they had arrested already, or 3 cases which they had arrested, I think. So.
Sure.
Well, maybe you don't have an idea. I'm living in Saudi Arabia, and you know that there are plenty of difficulties in the insurance problems and eligibility problems for patients who are coming to hospitals or even to big medical centers. Where can they have complicated surgeries, actually, or complex surgeries, let's say. So, as I said to you, I'm not advocating, but at least if such patients would have had VP shunts, maybe they wouldn't have arrested and would have reached to you to get operated in their countries in a safer position. After that, we can remove the VP shunt. Well, I know you don't like the shunt, I know you don't like the tubes, but sometimes when the social or the economic or the even the will of the patient, I mean, there are plenty of patients who are expatriates who doesn't like to get operated while they are in their expatriate country and they want to go to their family to get operated there. We have plenty of them, like Indian patients, like Bengalis, like even Filipinos, who likes to go back to their country between their family members to get their care there for their major surgeries there and then to go. I cannot, as you said, allow a patient with hydrocephalus with a high risk of proning during a long trip to change. Well, at that moment, I may offer the patient a VP shunt and let him go. Okay, depends on the circumstances. As I said, if I can go and get operating this patient here, I will not leave him. But this is the only case maybe I can just defend the idea of doing VP shunts for some patients. What do you think about that? I know you hate it. I know maybe that's going to affect maybe your surgery. That may be going to make a little bit difficulties. But let me hear from you again.
Thank you for raising this point. It's very important, and it is really affects me so deeply to see shunts put in this part of the world. I believe strongly that shunt in the Middle East, in the underdeveloped countries, in the Arab countries is a disease in itself. Residents are taught to put a shunt for all kinds of lesions without thinking. And when you look at the operative experience of somebody presenting to go into the exams of the Arab board or the Jordanian board, and you look at how many cases have you done, he would tell you 300 cases. And you would look carefully and you will find that there were 100 shunts and there were 100 revision of shunts of the upper end and 100 of revision of the lower end of the shunt. This should not be the case. We should not teach them that the shunt is the disease, is the treatment for all the cases. And the most awful is to put bilateral shunts. I agree with you, Abdullah, if what you have said is the exception. But this is the rule. This is the rule. And when you ask them, why did you put a shunt in the middle of the night? You would say, it's an emergency. Right, you can put an external drain, it's quicker. And then you can refer them to another surgeon to do. But as you said, it's for money. It is for not taking the courage to do the further step of doing the surgery. If he has put an external drain, then he's committed to do the surgery for the patient, which he can't. So we have to, I mean, there is no country in the world where you don't have neurosurgeons who cannot remove a colloid cyst or a SIGA or whatever. There are, but people are not happy to refer patients to the other experienced surgeons, and they put a shunt, which makes my life and the life of the patient miserable, and lots of troubles would occur.
I told you, I agree totally with you with the concept, but in special circumstances, which happened with your 3 patients, yes. I mean, I would have put VP shunt for the patient and send him with a trip of 2 or 3, 4. Yeah. No trip in the airport will take less than 6 hours.
Yeah, but they could have been also sent with an external drain, rather than.
I don't think so. Well, me myself, I wouldn't have sent a patient with an external drainage, which is lying down with tubes, you know, the legalization of sending a patient with such an external drainage, which needs to be adjusted for height and something like that. I think this is a little bit difficult.
No.
I prefer to send a patient with VP shunt.
You can refer patients with external drain, which is closed, but you send a nurse or a doctor with a patient. So there's no problem of sending patients on airplanes with external, which is
financially and administratively concerning the airplane companies. Plenty of them, they will refuse that. And that will be a very, very high cost on the families of the patients. You know, most of the expatriates in the Gulf countries, I mean, if I'll tell you 80 to 90% of them are having low salaries in comparison to the high medical treatment costs and the insurance coverage. Hence, I'm telling that if I'll be the doctor of a patient, I'll do VP. Suppose I had a patient, I'll offer the surgery, okay, but she's not covered by insurance, she's refusing to do it here. There is something. My second offer to her will be, I'll do a VP shunt and send you to Dr. Subeh.
I agree with you that these are special circumstances, and I would accept this argument, but this is not being carried out. In the same country, without travel, people are putting shunts. So what you are saying is a special...
No, in the same country, this is not acceptable.
Yeah.
I agree with you.
Thank you.
Okay, let's move on. Jalal has a comment. Go ahead, Jalal.
Hello, everybody. Hello, Dr. Subeh. It's great to see you again.
Hi.
Thank you for your nice lecture.
Thank you, Jalal.
Actually, I had a comment that if you treat a colloid cyst, especially in the VP shunt, I think it's there's no need to send it to Professor Subeh or others, because you close all the others way for treatments. The main treatments now is endoscopic, which is take time. Maybe as you puncture the ventricle, you can put your endoscope and give the patient chance, or give it the external drainage. But the VP shunt, it's treatment of hydrocephalus, not the treatment of the colloid cyst. So
Absolutely.
we are cheating our, and you close the way for the patient to cure from the colloid cyst itself.
Absolutely.
I have a comment because last week I did not attend your lecture live, but I attended on that YouTube for Neurosurgical TV. You mentioned my name in the reference as I'm proud of that, with 18 cases of colloid cyst.
Yes.
But I don't know from where you get it, because we published with Professor Al-Mufti in Controversy of Neurosurgery in his book, 28 cases with follow-up of about 15 years. So, and this is, I think it's good for endoscopic cases.
Absolutely. Absolutely.
Yes. So that's it. My second point,
because it is important paper in the treatment of colloid cyst, and with your name and the name of Al-Mufti, I thought it's worth mentioning. And I keep saying, and I keep repeating myself, that the future of neurosurgery lies in the hands of endoscopists. Endoscopy is the future of neurosurgery. So I believe strongly in its value and its progression in the coming years.
Yes, it's very important in colloid cyst because it's a vascular structure, and you can manage it not like the other tumors with endoscope. My next point is about the subependymal cases. I have two cases. One huge tumor, I did it transcortical, and the second one is less than 2 centimeters. I did it endoscopic, and it was okay. I sent it. Did this some meetings in the Arab meeting. And anyway, I put my comments on you and on YouTube for the new research with Professor Al-Mufti. I think it's better if you like to add it. Thank you very much.
Nice to see you, Jalal, and I hope you are doing well. Where are you located now?
I'm actually from border of the Syrian-Turkish border. My family in the Turkish border, and I'm practicing in the north of Syria.
Keep well and say hello to all my Syrian colleagues. I miss you all.
Thank you very much. Thank you.
Dr. Jalal, nice to see you. We have met maybe in Damascus in the meeting on 2010, if I'm not mistaken.
When Yazergil was there, it was 2008.
Yazergil was there, and
it was 2008. And
no, 2008, 2010. Sorry, not 2008. Yazergil was not there. I think maybe it was the Syrian group, the Syrian Neurosurgical Society, which was led by Dr. Minyawi and some others, if you remember.
I was the secretary for 8 years for the.
Exactly, and you presented 1 or 2 cases of colloid cyst endoscopical treatment, and I have done 2 already at that time, but you presented a nice lecture at that time. Well, I just have a small comment on your comment. When we are putting the shunt for the colloid cyst, we are closing the space.
Yes.
Well, as I said, I'm not advocating, I'm exactly like Dr. Subeih is telling, I'm not advocating the VP shunts as a treatment for such patients, but in some special circumstances. In the time that we are having in Syria now, there are plenty of patients or plenty of centers, they don't have facilities for complex surgeries. They need to go to Turkey, they need to go to Jordan, they need to go somewhere else. So if any surgeon who can manage such patient to tolerate the trip, I think this should be done. And then later on, as a surgeon, if I want to go endoscopically, I can just go and clamp, body clamp for this VP shunt, okay, close it, and observe the patient for a couple of days. And when the ventricles are redilated again,
your patient will deteriorate.
Endoscopy. Excuse me?
Yes, I have some big cases. If you close the shunt, the patient will be shunt dependent. And within a few hours, the patient will be comatose. It's very risky to close the shunt. For shunt dependent, yes. I have tried this one time.
Well,
I almost lost my patient.
No, well, if you put the PP shunt for a long period, for more than months, 2 or 3 months, I agree with you. But if the patient was having hydrocephalus and you treated this hydrocephalus with a medium pressure shunt or a little bit high pressure shunt, or programmable ones, I think still you can have the time for 1 or 2 days, 3 days, until you will have dilatation for the ventricles, and then you can go endoscopically or surgically and treat this patient. I mean, I cannot accept that my patient will come from here and I will leave her doing nothing for her to go to Dr. Subeih or to come to you or to come back to me because she has no other circumstances except doing that, and then she will have arrest. I will not forgive myself all my life. Okay?
Yes, but I want to tell you something that I learned my endoscopy in Saudi Arabia. I attended 3 times in 1995, 96 with Gab and Bernesky for 3 years, and then I bring it to Syria.
This is nice. Well, I learned endoscopy in France with St. George. I went to Gab himself and stayed about 1.5 months with him for endoscopy, and I've done plenty of cases. And well, believe me, I'm sorry, I'm elongating this discussion, Dr. Subeih, but still, in some special circumstances, as Dr. Subeih agreed also, maybe we have to do that. Maybe.
Yes.
Maybe.
Some cases you have to put a shunt, no doubt about it, but it should not be the common practice.
It should not be the rule. I agree totally. Yes.
The majority of practice. I agree.
Very good. Any closing comments or questions? Go ahead.
Yes,
Hold on. Let's give someone else a chance. Moha, go ahead. Go ahead, Moha. Could you go ahead? Moha, you had a comment? Go ahead.
My question is from Professor Ibrahim. Is that what's your opinion if we consider surgery for the every little subependymal tumors around the foramen Monro area, especially fornix. Also, there is some important around the foramen Monro. And also, you told that some of these tumors will be vascularized and there is danger for the future of the surgery. And also you consider that it would be in the future, we consider because of hydrocephalus, we consider arresting for the patient and mydriasis for the patient. So my opinion is, and what's your opinion, if we consider surgery, early surgery for every small little for damaging for.
Right.
Can you understand that at all, Dr. Subeih?
I did not hear all the what he said, but I think he's just asking whether there is a place for going for small lesions of SIGA, subependymal giant cell astrocytoma, before they get larger. I'm against that. I don't operate on something asymptomatic, which is not causing any problem. If it is not causing hydrocephalus, usually it is asymptomatic, and these patients are going to develop some subependymal nodules here and there. So I leave it to deal with the culprit of the symptoms of the patient, but I would never operate on a patient who is asymptomatic.
Okay, very good. Okay, well, we're going to close it up, Dr. Sabea. Thank you very much. Do you have any idea on the topic next week?
No, but I will shortly tell you about the topic, and we'll do it next Wednesday, inshallah.
Dr. Bennett, I have a small comment only, please.
Okay, go ahead.
In the last three sessions, we had problems to enter into the Zoom program, to the Zoom
yeah, we'll talk about that after, okay?
Each time it's telling that you are on another
session. We'll talk. Okay, I understand. We'll talk about that after. Okay. Okay. Thanks everyone for coming, and we'll wrap this up. We'll see you next week.
Bye.
Thank you. Okay. Yeah. Okay.